Neither the El Paso Medical Society, its members, nor PBS El Paso shall be responsible for the views, opinions, or facts expressed by the panelists on this television program. Please consult your doctor.
In order to prevent the spread of the virus, we all need to do our part. One of the easiest ways to prevent that is by wearing a mask. In order for a mask to do its job, it needs to cover your nose, your mouth, and your chin. First, you should wash your hands with either sanitizer or soap and water before putting on a mask. Then pick up your mask by one of the ear loops to make sure that there's no tears or stains on the mask. If it is dirty, throw it away immediately. If it's intact, take both loops and put it over your ears like this, and then press down on the bridge of the nose to make sure that it fits and there are no gaps. Once you are done with the mask, please take it off the same way. Both ear loops, pull it away, and put it either in a Ziploc bag or throw it away if it's a surgical mask. If it's a cloth mask, make sure to wash it with soap and water and keep it dry for the next use. Do not put your mask down at your chin or above on your forehead when you're starting to remove it, as that just contaminates the mask. Thank you so much for doing your part to prevent the spread throughout the state.
1 in 4 people die of heart disease in the United States. Those numbers are pre-COVID, but we are here today to let you know that if you are having some kind of a cardiac situation, that you absolutely should indeed go to the hospital even in this time of COVID. It's very, very important. We are also here today to make sure that you know how to take care of yourself at home as well. The title of the show is called Advanced Heart Care at Home. During the next hour, we have experts answering your questions about advanced treatment in heart disease, including detection, intervention, and beyond. As you know, this is a live show, so if you have any questions to ask us this evening, call us at 880-1313. This evening's program is underwritten by the Hospitals of Providence, and we also want to thank the Texas Tech Paul L. Foster School of Medicine for providing medical students to man our phones. Today with us, we have Myra Perkins, who is helping us out with the phones, and do give her a ring. What she does is she interprets what you are asking, writes it down, and texts the questions over my way. So she's competent and wonderful about that. I also want to say thank you very much to the El Paso County Medical Society, who has been bringing the show to you for 23 years. Good evening, I'm Catherine Berg, and you are watching the El Paso Physician. Thanks again for joining us. We have 2 experts here today, and there's a lot that we're going to be talking about. Specifically in the world of cardiology, we have an interventional cardiologist, and that's Dr. Edward Ossie. Thank you for coming here. And this is his 3rd time here, but I feel like it's your 20th time here. You know, he's really good about explaining things. So again, if there's questions you have, give us a call at 880-1313. We also have Rob Anderson with us, who is the CEO of Hospitals of Providence at the Sierra campus. And Rob is going to talk to us about policies, procedures a little bit, but also the ranking of what's going on with certain heart care. And this is your first time here, so you're the rookie.
It is. Pleasure to be here.
Well, I'm glad that you're here. Very glad that you're here. I'm going to start off with Dr. Ossie. And Dr. Ossie, we have a heart. And actually, you know what I'm going to do? Interventional cardio. Let's do that the second question. So let's talk about, when I said cardiologist, I had that on my paper, and I said, oh yeah, remember interventional cardiology. Explain what does that mean versus just cardiologist?
Well, whether you're an interventional cardiologist or not, we basically do a whole gamut of things. But being interventional, I am a cardiologist who has to go to the emergency room, take care of someone coming in with a heart attack, to be able to take them to our heart lab, where in our heart lab we use balloons and stents to open up clogged heart arteries. That basically, and there's many other facets now that have become interventional cardiology, such as dealing with structural heart disease, which we'll touch on today. As an interventional cardiologist, we are all partaking in that aspect of cardiology. But on a day-to-day basis, I'm also seeing patients in my office, taking care of, general heart complaints, not always just the patient having a heart attack.
Exactly. And I love, and I don't know if some of the audience can see we have all kinds of toys today, and I'm super excited. Dr. Ossie came with this beautiful thing in a big box. He's like, should I take this out or would it be scary? And I'm like, we're all about showing what this is about. So I thank you wholeheartedly for that. Rob, as you, so you were talking about, you've been here 9 years now, and I thought it was longer too. When we are looking at the Sierra campus of Hospitals of Providence, what do you do all day, every day? And I would love for you to kind of integrate what it used to be like prior to like February of last year, and kind of what it's been like over the last 12 months. So kind of talk about before, and then just, oh my goodness, over the last 12 months.
You know, absolutely. And again, I'm excited to be here. First of all, I want to say thank you to all the healthcare providers and the frontline workers. It's been a tremendous struggle in 2020. In 2021, I think started off kind of rough. But again, a sincere thank you to everybody. It's been tough for everybody, whether it's a EVS, it's a nurse, it's those individuals working in restaurants. It's been tough. So thank you to everybody. But as a CEO, my main goal is to really focus on the patient satisfaction, physician satisfaction, and patient care. And it's overseeing all of that. At Sierra campus, we have about 435 employees. That includes nurses, first assist, OR techs, EVS, our food workers too. So my job is to really oversee all of that, but let the nurses, let the physicians such as Dr. Ossie do what they do best. Take care of those patients. During COVID, again, my hat's off to all the hospital systems here. I think we worked really good together to function as one. The function as an El Paso community to, ensure ICU bed capacity, ensure beds are available, ensure we had nurses, ensure we had PPE. And so, during 2020, I think most folks were focused on the COVID, safety for patients, safety for staff, and just getting us through this pandemic.
And I do want to, since we're talking about COVID, and I'm going to do this several times throughout the program, vaccines, and I have to give a shout out to Hospitals of Providence. We had Nico on several months ago, and it's just, El Paso is just rocking it when it comes to the dissemination of vaccines. Now, I get that there's frustration because there's not enough vaccines to disseminate.
Right.
But once we really start getting the vaccines, the way that it's been put together is great. And everyone that I've spoken to that has been able to get their vaccine just because of their, what position they are in line, so to speak, it's been a smooth process. And that's due to El Paso, that's due to the hospital systems all working together, it's due to the county, it's due to the city. On that note though, if you have not registered for your vaccine yet, here are two ways you can do it. You can do one online, and it's actually easier than you might think. So the website is EP, just think of El Paso. The website's epcovidvaccine.com, epcovidvaccine.com. On the opening page, there is a top button that says register for the vaccine. It says it right there, right when you get to this website. So it's nice and easy to find. If you are a person who'd rather telephone, the telephone number is 915-212-1032. It's on your screen. I want to say thank you to Gracie for putting that up there. So again, the telephone number 212-1032. We're going to flash that up several times throughout the show, and when it comes your turn, definitely get the vaccine. Again, that herd immunity.
Yeah.
Thank you very much, sir. Everybody who watches the show know I misspeak all the time. Dr. Ossie, I want to talk about just heart complications just for a second, just to touch base on it. Heart complications when it comes to COVID. I know it's not really on here, but some of the complications that we are hearing, at least in the very beginning, one of the first ones we're hearing, are what different complications can happen to the heart with people who have had COVID. Then there's the long haulers too. Let's touch base on that. I don't want to focus too much on that.
Sure.
But what you're seeing or experiencing or reading.
Yeah, I mean, we have seen patients come in with COVID and they can develop a heart attack. They can develop shock from a condition called myocarditis, which is inflammation of the heart muscle, where the heart muscle stops working as efficiently as it should. And those are, COVID is an inflammatory state.
Right.
So the vessels in the heart become inflamed, the heart muscle can become inflamed, and those conditions can create dire situation for a patient.
Yeah.
I mean, Catherine, I
yes,
think one thing
Rob?
that Dr. Ossie, kind of touched on, the challenge we've had during the COVID pandemic is individuals did not seek emergency care, right? And so they felt chest pain, they thought, oh, it's okay. I'm more worried about getting COVID than I am, making sure I'm all right. So across the market, nationally, and including El Paso, our emergency room visits down 20% for the first quarter, and then year over year down 42% for emergency room visits.
Right.
And so, a lot of that time, it was heart pain, it was chest pain, that they just thought, it's okay, I'm not going to seek, care. And the challenge we had is that they come in later on,
Right.
and their disease is more severe than it was,
Right.
and poses a challenge, for the patient and for the physician.
So I love that you're bringing that up. On that note, so bottom line is, if you're having a cardiac situation, and you would, or if it wasn't COVID time, if you would call the hospital, call the ambulance, still do that, because there is no safer place right now for you to go than to the hospital. All the protocols are in place. And on that note, I'd like for you to talk about what protocols you have in place. Like if someone's going into the emergency room, if you can maybe walk us through what they're going to be seeing, who's, what are they checking, et cetera, just to make people feel comfortable that they can do that.
Yeah, again, it's a challenging time, right? And I think everybody is coming through the emergency room is going to be screened. They're going to be screened for the temperature, asking the questions. Have you had COVID? Have you been around COVID? Do you have symptoms? That's the front line, right? And I'm going to encourage people to be honest with us, with the screeners, that if you've got those issues, say, yes, I do have those symptoms. And then if they are COVID, they're going to be sent on a separate pathway than those that are non-COVID.
Okay.
So they will go to the emergency room. They'll be treated. It's dividers that's up. The ventilation is proper. So the safety precautions are there. Everybody has PPE. And everybody's covered. And so, you're right that I feel that the hospitals are more safer now than they were 2 years ago, just because of these extra precautions that we put in place. And so, for individuals, especially in the emergency room that are having these emergencies, you need to call 911.
Right, exactly.
Right, because EMS are following that same too. Or if you can, drive yourself to the emergency room, but you'll be safe there.
Yeah, exactly.
It's okay to go. And I think, our challenge from the hospital side is getting the education out that it is safe to be at a hospital. And if you're having symptoms, please come in. Please come in.
Please come in. And it's, again, that is a place that has it down, absolutely has it down. Employees are screened. I just want to say that out loud too. Employees are screened all the time. So if they're thinking, well, what if somebody that works at the hospital's got it, they're around it all the time, it's definitely the place to go.
Yeah, I mean, the employees are screened on a daily basis, right? And we have 2 different shifts. Employees come in and they're screened all the time. Does it get a little redundant? It does, but it's the right thing to do. It's the right thing to do for the patients. And so, we're wearing masks, we're wearing gowns, we're wearing, face masks and, shields when appropriate too. So the hospital is a safe place to be. And again, if you're having those issues, you need to come to the hospital.
Absolutely. I'm so glad that we talked about that. Now, Dr. Ossie, it's time to break out the toys. So we're talking about cardiology, we're talking about the heart, and we're talking about structural heart issues today. You've got a great model of the heart, and what I'd like for you to do is point at this camera here, and just, I know it seems like, cardiology 101 to you, but it's nice for the people at home to see what we're looking at and talking about this evening.
Of course. So of course, everyone focuses when we talk about the heart about having a heart attack, and that is related to these red pipes that lay on top. The red arteries are the ones that become clogged with cholesterol and can develop into a heart attack. But in addition to that, there's multiple other areas of the heart that we've had an increase in interest in. And basically, when you start opening up the heart and start looking at the chambers within the heart, there's 4 major chambers. The 2 upper chambers are the atrium, and the atrium basically pumps blood down into the 2 main ventricles, the left ventricle and the right ventricle. Now, the way I kind of look at this is blood has to travel through each of these chambers, and in order to do that, they have to get through these valves, which I basically call one-way doors. They open and they close in order to allow blood to circulate through the chambers of the heart, go to the lungs, and then come back down to the main pumping chamber that pumps blood through another door called the aortic valve, which you can see right there, goes up through the aorta, this big pipe right here, which then delivers blood to our brain and all of our organs. And so not only now do we focus in on the heart arteries and heart attacks, but we're starting to deal with structural problems with the heart when it comes to heart valve problems. And take, for instance, the two most common heart valve problems that occur in adulthood are one that is related to the mitral valve, and then the other one is related to the aortic valve, which is this three-cuss valve right up in here. So at this point, you know, we start to develop problems as we get into adulthood with these valves, and these valves then can be treated through other ways other than the traditional way, which has been open heart surgery.
Right.
I mean, and it's not that open heart surgery has gone away. We are still an avid surgical program. We have a great surgical team, and surgery is still an option, and a good option for many patients. But this new technology that we're using to treat heart valve problems has come about recently, within the last 10 years, and has progressed and grown exponentially.
Right. You were talking about surgery, you were talking about teams. Rob, I'm going to throw it your way for a second. Sierra campus of Hospitals of Providence was recently named a heart care center. Tell us what that means. So it's, you know, what it means to be accredited. It's the American College of Cardiology, et cetera, et cetera. It's a big deal.
Yeah.
And I'd love for the audience to understand, when they're looking for credentials in different cardiology situations, what that kind of stuff means.
Yeah, you know, so the American Cardiology is really, it's the place to be, right? It's the place to know, it's the experts, it's the resource for anything cardiology. And so one of their designations is the Heart Care Center designation. And what that means is that a hospital system is really, they're dedicated to cardiology, dedicated to heart programs. They have the outcomes, they have the length of stay, they have the education, and they're treating patients in the right way. And so really, you know, essentially what this is their stamp of approval to say this program provides the best patient care. What's good about the heart care program, especially in El Paso, is we're one in 34 designated hospitals across the country that has this. There's only 5 in Texas, and of course there's only 1 in El Paso. So you know, this just shows the dedication of Sierra campus, of really what we are and who we are. And it's a true testament to the physicians, the cardiologists, our nursing staff, and the dedication we have to El Paso.
Nice. And it's all about the teams. And again, we've been on shows before when we actually had 3 people. We're social distancing, we only do 2, but it's all about who does what in the teams and that team effort. Let's talk about structural heart disease. I'm a mitral valve gal. I was one of those people that grew like 4 inches in a year, and so structurally, a lot of people that do that, you know, the soft tissues don't go along. But in general, just some structural heart issues, diseases. I think diseases sometimes might be a misleading word, but just some heart issues. For me, it's chronic, but it's pretty benign at the end of the day. You know, we checked all that out. But talk about some structural issues.
Yeah, I mean, 2 of the most common structural issues that we're dealing with today is dealing with the aortic valve, which is basically the main door that allows blood to exit the heart and go out the aorta. That valve in adulthood is probably the most common valve condition that we deal with, along with mitral valve disease. Those 2 are really the main valve issues that we see in adulthood. Aortic valve disease is one in which there is degeneration of the valve over time. This valve, that main valve, takes, I always say, the max intensity stress.
Right.
It's the one that is basically getting beat on the most, because that's the main pumping chamber of the heart, is pushing blood out through that valve. And then that valve starts to get inflamed, get a little cholesterol buildup on it, and then in later life, calcium deposits really take over and then prevent the valve from no longer opening. So the door becomes very stiff and resistant. And that is one of the main structural heart problems that we are dealing with in our day-to-day society today and at the Sierra campus. There's structural disease that can occur to the mitral valve. More commonly, it causes the valve to leak instead of become stiff.
Right.
There's other potential problems that can occur with the heart, such as a condition of atrial fibrillation, where we are predisposed to stroke. And there's a little pouch right here that's called the appendage that sits on this top chamber of the heart, and this pouch houses the majority of thrombus or clot that causes stroke.
Really? Okay, show me that again, because that makes me curious. So in
So
that
here's
one
the
area,
left atrium,
right.
which is the top chamber that delivers blood down to the bottom chamber.
Gotcha.
This appendage has been there all our lives, and it really has no real need for us at this point.
Gotcha.
It has become a nuisance to us because that is the area that 90% of the time, if you're going to form a clot from atrial fibrillation, it's going to be housed in that little unit.
How nice that you know that, though. Seriously, that you know that you can figure it out and find it there. Okay, my apologies.
So
Yeah.
we typically, the mainstay, the standard of care of treating people with atrial fibrillation to prevent clot is to put people on blood thinners. But there's a small subset of patients that can't take blood thinners. They have bleeding problems. And so there's a structural technique that can be done to basically close off this appendage in order to prevent patients from having a stroke that can't take blood thinners.
Right, right.
So there's all facets of structural heart disease. The one that we see most commonly and that has developed significantly over the last year and a half at the Sierra campus is the treatment of aortic valve stenosis.
Okay.
Stenosis being that the valve no longer opens properly, becomes stiff, and it causes the patient to develop common symptoms that
That's
sometimes...
exactly what I was going to. How does one know if they're having issues? You know, I mean, that's, for example, we have some shows that are like, okay, heart pain that isn't your heart. Is it pain? Is it losing your breath? Is it a combination of the other? So you're talking about structural issues. And let's just say it's someone who doesn't go to the doctor like they should every year. What are some of the symptoms that we're looking at with what you're describing right here?
So the early symptoms, which are if you opened up a textbook and you said, well, give me the classic symptoms of aortic valve stenosis or a stiffened heart valve, the classic one is that someone's going to develop heart failure, they're going to pass out, or they're going to get chest pain called angina. But those typical symptoms, those classic symptoms, are typically at the very end of the disease.
So, yeah,
we
so
want
it's
to
hard
catch
to find it
people way before, because when you start to develop aortic valve stenosis, there's a very long period where the patient may not have any symptoms because the valve doesn't become stiff overnight.
Right.
It's a long progressive occurrence. So when they start developing symptoms, the most common are going to be exertional shortness of breath. So if I'm, carrying the groceries in and I have to stop and rest because I'm getting short of breath, that can be a very common symptom of aortic stenosis. Exertional fatigue and exertional dizziness. So, I've had patients that have come into my office and they're taking the trash out, they're climbing up their driveway,
Right.
and they almost feel like they're about to pass out. And they have to lay down on the floor so that they don't pass out. And those are some of the, cardinal signs that this is a major valvular problem of the heart.
So listen to your body. And again, as we were talking about before, Rob, if there's an issue, definitely call. If you have a physician, and hopefully most people do, if you have a physician, call your physician, go get it checked out. If not, if you are feeling dizzy over and over again, I call it lightheadedness. My family, it's just, we surf the wave, but it's very, very important to do that.
And
Yes,
the question I have
Rob?
for Dr. Ossie that I get quite often too, and I know I've asked you before, is is this hereditary? Are you born with some of these issues, or is it as you get older, which I know majority of heart disease problems are 65 and older? How does that flow And as my 6-year-old, should I be concerned about his heart, or is it something that he's going to get over time?
Yeah. Well, so aortic valve disease, the most common cause of it is what we call senile calcific disease, meaning that as we get older, you develop calcium on your valve. In fact, when you get into your 80s, it affects near 10% of the population.
And your
this
aortic
valve
valve
condition,
Okay.
aortic valve disease.
Interesting. Okay.
Yep. And now there are genetic predisposing factors that can cause your valve to degenerate earlier, such as a bicuspid aortic valve. So as I had mentioned earlier, the aortic valve has 3 cusps. Let me see if I can point that out a little bit closer. So as you can see right in there, there's 3 leaflets, 3 cusps of the valve.
Point it down just a little bit. There you go.
Yep, 1, 2, 3. So that is a normal tricuspid valve, but there are patients that are born with what we call a bicuspid valve, where there's only 1 slit between and only 2 cusps. And that can predispose someone to the development of aortic stenosis at a very young age. In fact, before the age of 50 sometimes, they develop enough calcium on the valve, and that's a genetic condition that can be transmitted that can predispose you to aortic stenosis.
So I always like to ask on cardiology shows, with oncology shows, there's screenings. I know that there's not technically screenings for heart issues, but if there was something that if you decide to go to the doctor, let's just say you're one of those, and shame on you, if you go once every 5 years, you really should try to go once a year, once every other year. What are internists looking for to see, for example, risk factors? Let's throw risk factors in there as well. What are internists looking for to say, I think you may have something going on with the heart?
Yeah. Well, it's a great question, and as we know, there are certain risk factors that predispose you to heart disease, and we know them as diabetes, high cholesterol, high blood pressure, smoking, family history of premature disease. So when you start having those risk factors, your risk of developing heart disease starts to go up. So as the primary care physician sees them and sees all those risk factors, it starts to make them more aware and heighten their awareness of everything. And the interesting thing is the risk factors for the development of coronary artery disease, the blocked heart arteries, also are risk factors for the development of aortic stenosis.
Right.
It's almost the same pathology early on, but with valve disease, it becomes more of calcium rather than cholesterol burden later in life. So as the internist sees the patient and starts to hear about all their risk factors, that should raise a red flag that maybe you should be evaluated by a cardiologist.
Bingo.
The other thing that's extremely important is a good physical exam, because a lot of internists, great primary care physicians, will listen to the patient, hear a murmur, which a murmur is no more than turbulence of blood flow.
I'm glad that you explained that.
Yep.
A lot of people say, well, I've got a heart murmur, I've got a heart. What does that mean?
Yeah,
Yeah.
it's turbulence of blood flow. Take your garden hose and kink it, and it makes a funny noise, right?
Exactly.
So as blood moves through a stiff valve, it creates turbulence of blood flow, and we hear a murmur.
Catherine, kind of take a step back on the screening events. During 2020, it was very difficult for us to do screening events. So the Hospitals of Providence, we do those. As a matter of fact, on February 27th, we're doing that from 7 a.m. at our specialty campus to provide the community an opportunity that if they're not seeing an internist or not seeing a cardiologist, to come in and get their heart checked.
Right.
That's important. This is February is Heart Month,
Right.
which is why we're here, and is really to educate everybody on the severity, to get your heart checked. It's a pretty important part of your body, and to go get it checked. What can it hurt?
So repeat what you just said, because I think sometimes there are things worth repeating, because there are some people who are watching the show that don't have a family doctor, don't have an internist. Repeat again what they can do if they are experiencing anything that Dr. Ossie was talking about.
Yeah, well, I mean, first of all, if they're having severe challenges, call 911.
Yeah.
And we have to do that. And if you're not seeing an internist or a cardiologist, to go get checked, to go get screened. We're offering a free event on February 27th from 7 a.m.
I actually have a question about that. Yeah.
To 10 p.m. at our specialty campus there. We'll have advertisements out there too, because you need to go out and you need to get checked for that. We're putting out a lot of educational events just to bring awareness to the heart, because it is such a critical piece, and it is, you know, for the El Paso community, it's a situation that we need to make sure we proactively get in front of, so we're not getting to the point where we're having to, you know, see Dr. Ossie,
Right.
you know, to be in a cath lab.
As much as we like Dr. Ossie. So I'm going to repeat this. February 27th, you're having an event. Is it the Hospitals of Providence Sierra campus?
But it's at our specialty campus,
Okay.
which is about 250 yards from Sierra campus. It's on
Okay.
Murchison Drive.
Okay, on Murchison. And what exactly is going to be going on? Are there going to be people out there checking you out?
There's going to
you
be
know,
nurses
taking-
and physicians doing EKGs, doing blood pressure checks, just doing some of those initial screenings to see if you are at risk.
Excellent. Okay.
And then if you are at risk and you don't have a primary care, you don't have a cardiologist, we'll provide you with a list of those so you go, you know, so you can go seek care.
Nice. And do you know what time it starts by chance?
7 a.m.
7 a.m. till people stop coming.
Correct.
I like that.
Correct.
Okay, we're going to repeat that. Make sure we repeat that at the end of the show as well. I'm starting to get questions in from the audience. Maria and Guillermo, thank you very much. I love that you're giving me names. Way to go there, Myra. Dr. Ossie, what I'd like to do before we get into the questions, because one of the things we really wanted to talk about today was about TAVR.
Yes.
So there's this procedure. And let's start the conversation on that, because I know we have a lot of cool things to show people.
Sure. Well, TAVR, transcutaneous through the skin approach, aortic valve replacement, but it's actually not a replacement. It's kind of taken on a new name of implant. So TAVI, transcutaneous aortic valve implant, is a way to treat someone with severe aortic stenosis with symptoms without doing open heart surgery. Now again,
That's a beautiful thing.
yes.
Yeah.
But again, open heart surgery and what we call SAVR, surgical aortic valve replacement, is still a very viable procedure, done really well by our surgeons here. But we're finding that there are sometimes certain age groups that would benefit more from surgical or transcutaneous without going through open heart surgery. And so what we've been able to do is, especially our elderly population, you know, especially our patients that are in their 70s and 80s,
Right.
that we know that open heart surgery would be a more difficult procedure for them. We are taking those patients and evaluating them for this procedure. And one thing I really want to emphasize is that this procedure, TAVR, has opened up the doors for all of us to become colleagues once again. So it doesn't matter that I'm in one group and then the physician is another group, or the surgeons who have always, you know, it's cardiology and then it's surgery and there's a line in between us. We are now a multidisciplinary team that we are all working together. We all sit at a table to discuss these patients and what is going to be the best approach for the patient.
Nice. Right.
And we do it in a very collegial atmosphere. We talk about it and get approval.
My
of what's gonna
background
be
is
best.
oncology, so I think of tumor board, right? The old days is a tumor board. Everybody comes together, they look at this particular case study, what's the best thing to do? So it's in essence that kind of a strategy, correct?
Absolutely.
And this is
Okay.
what you know, Dr. Ossie is talking about, is what the Hospital of Sierra campus brought to El Paso 2 years ago. And we're the only campus, only hospital that has the capabilities and the abilities to do this TAVR procedure. And there's 5 implanting surgeons that are doing it. And again, like Dr. Ossie said, that's what's unique and great about this, is that all of these, you know, these cardiologists and surgeons are coming together to do this. And again, it's another procedure that the Sierra campus, has brought to El Paso, because historically, either one, you didn't get it,
Right.
or 2, you had to go to Phoenix, to Dallas, San Antonio, you know, to travel to get those procedures. And it's not only you going, it's your entire family.
Exactly.
So now we're bringing this to here to El Paso, so you can do that.
Right.
So you have these other options to take care of yourself.
And you have your support system. That's such a big deal. Every time we
Absolutely.
talk about trying to keep whatever your treatment is at home, you've got your support system, you've got your own home, you navigating mental issues are really, really big when you're trying to recover. That's super helpful as well. Dr. Asi, what I'd like to do, I'd like to talk about the scary thing.
Okay.
Because it was so great. So what does this, we were talking about, this is how we deploy the valve, right? Is that how you're saying, or deploy the?
So to implant the valve
Implant
or
the valve,
deploy
yes.
the valve.
You were joking
correct.
about the word deploy, but
Yes.
but yes.
So again,
I'm going to have you hold this because
Yeah.
otherwise they won't be able to see.
so I just want to show that this is basically a device that we use to implant the valve.
And I'll
It basically,
try to
when the
show
patient
end.
when the patient is in the room, and typically the patient is asleep, we access the right groin in order to deliver this system. So the valve actually sits down here, down on the very end, and is deployed
And
in
this
the
is what
patient.
the valve looks like, just so we can kind of.
Yep, there's
don't know if
two
you can
types of
kinda-
valves. There's that one valve, and then there's this other type of valve. And there's differences between the valve, and most of the patients do well with either one. But we access the artery, the femoral artery, through the right groin, and we take a delivery system, this, up through the major pipe called the aorta, right here, and cross in through that valve in order to deploy the valve. And so we use this mechanism here to allow
Actually
us
pull
to.
that up so they can kind of see. So there's a mechanism that you're operating.
Yep, there's a mechanism that we're operating, and it typically is a two-man team. So the surgeon and myself, or we have another, possibly another interventional cardiologist, but we are working together to deploy the valve under fluoroscopy or X-ray, so that we see how the valve is getting implanted, and if we need to maybe recapture it or bring it, we have those abilities to do that with these systems.
And so much less invasive. You know,
So much
that
less
is
invasive.
amazing to me.
Most patients will go home the following day.
You're kidding me.
No,
Really?
they're being discharged typically the following day.
Okay. On that note, when the operation's finished, surgery's finished, they're now in recovery the following day, what are they feeling? What are they, and it's different with every patient, and I get
Sure.
it. Are you waiting for them to get up and walk around for a while? Or what is it that allows them to go home? Does that make sense? All the little stair steps that you need to get there.
Well, the biggest issue is we want to make sure that their groin is okay, because as you can see, this is not a small needle that goes in to
Right.
the artery. It is a little bit bigger hole, so we have to make sure that the artery is in good shape for the patient to sit up and start walking around. And once that looks good, the following morning, we are getting the patient up, moving around, and allowing them to ambulate so that we can see how they feel. But most of the time, patients, once they start moving around, they start to notice a big difference.
That's what I want you to talk about, because there are so many people, and Rob, you hit the, what is it, the hammer on the nail?
The nail on the head.
The nail on the head, I always say the wrong thing. When you were talking about waiting, we're in the time of COVID right now. People are like, I can wait. I have heard through several shows too that people wait too long. And this is prior to COVID. This is not even in
Right.
the time of COVID. Again, talk to people why it is that they shouldn't wait, and how quickly in so many different procedures. So your entire hospital CEO. So we're talking about orthopedic issues, we're talking about cardiology issues, we're talking about everything. Why again should people not wait to go in this time?
Yeah, and I just think, it's a safe environment because, healthcare can't wait.
Right.
Healthcare shouldn't wait. Yes, COVID's been a big frustration for everybody, but we've got great nurses, great infection prevention controls. We got great surgeons that are here, and to seek medical care as soon as you can. And for this instance, in this case, you're there maybe a day and a half.
Right.
You're there overnight, and
That's
you're
amazing
home.
to me.
And you're home. And so it's essentially an in and out procedure, and you're back home to where you should be, with your family. And it's the right thing to do, and it's still a safe place to be.
Exactly. Question here, Maria called earlier today, I was talking about that. So questions from the audience really quick. We have Maria that's asking, where can people find a cardiologist to help them with problems in El Paso, and do they speak Spanish? Do you have a telephone number equipped in your head by any chance, Rob? I didn't ask you this ahead of time. If not, you can call the Hospitals of Providence, search engine the Hospitals of Providence, and telephone the main number and just ask for the cardiology department. So
yeah, and you can go to our website, thehospitalsofprovidence.com, too, and you can search for a physician search. You can search for cardiologists within your zip code, and then you can also search in there that speak Spanish.
There you go.
And then you'll have a list of all the cardiologists that speak Spanish. And so it's a good resource, and you can access it that way.
Nice. And again, use the word thehospitalsofprovidence.com.
Correct.
Question here from Guillermo and Dr. Asi. What is a Watchman procedure for the heart? And again, disclaimer, if we don't know the answer, we don't know the answer. We'll do the best that we can, but Watchman procedure for the heart.
No, actually, it's a good question. I mean, because a lot of people are talking about it, but it actually alludes to what I was talking about before. It's the occlusive device that closes off the appendage of the heart to prevent stroke. It's like a little umbrella that goes into the pouch and is delivered, again, transcutaneously through the skin.
Through the skin, I love that, yeah.
Okay, and it's deployed. The Watchman device is a occlusive device that closes off the appendage to help reduce the chances of stroke from atrial fibrillation in patients who are really felt to be not a good candidate for blood thinners.
Right.
And such as the TAVR, the Watchman is the procedure that is only done at Sierra campus.
Okay.
There are a handful of interventional cardiologists, electrophysiologists that have the capabilities and abilities to do Watchman. And so for, I think you said his name was Guillermo, you can do that at Sierra campus, and Dr. Asi can, find you the proper, surgeon that can do that.
Excellent. Dr. Asi, you touched base on stroke, and really we haven't talked about stroke too much tonight. And I think that that's so important too, because again, we're in COVID. Stroke has some pretty specific telltale signs. Let's talk about what those are. And again, the question always is, do I drive myself to the hospital? Do I call 911? What is the golden hour when it comes to cardiac issues? And let's talk a little bit about stroke if people think that they may be having a stroke. And sometimes the person who's with you is the one that's realizing you're having a stroke.
Yeah, of course. And time is brain and time is heart. So anytime you start to feel symptoms of a stroke, you lose your vision, you're having garbled speech, your speech is incoherent, whoever's with you feels that your face is drooping, part of your body you're having numbness or you can't move it, you can't wait and see if it gets better. You have to go in. Or if you're having chest discomfort, pressure, going to the jaw, going down your arms, you start to have those symptoms, it's never wrong to go in. It's always better to be safe than sorry. And the longer you wait, whether you're having a stroke or having a heart attack, you're damaging more organ.
And if you're alone, call 911.
Call 911.
It's not worth trying to drive yourself.
No.
That's something I would like, and thank you for throwing in, because the second part was heart attack. So again, if people think they're having a heart attack, that's what you're talking about, the pressure, the numbness, the dizziness, like you said, vomit or feeling nauseous. That's all I can think of. What am I missing?
Shortness of breath.
There you go.
Breaking out into a sweat, nausea, chest discomfort. I mean, all those are signs of a potential heart attack.
Okay. We are, yes, Rob, I heard you stutter start.
Well, yeah, I was going to say that I think it's important that the individuals understand, and Dr. Asi, I'll ask you, since you're the expert of this, of a stroke versus a heart attack, right? And so two different issues there. Sierra campus is a comprehensive stroke center. So what we found though, in 2020, we saw the emergency room visits go down. So a lot of individuals that had strokes thought it's okay, same they did with the heart attack. That I didn't want to go into the to seek care. And as you mentioned before, need to call 911. Exactly. Need to call 911 to get them into the closest stroke center, depending on where they live. And so again, I think individuals understand the difference between those two.
Absolutely. But each one of them, you cannot wait.
Yeah, just come into the hospital. Got another question here from the audience from Bernie. Bernie says, wow, 30 years ago, way to go, Bernie. Bernie got a mechanical valve 30 years ago, and he is wondering, he's been listening to TAVR, can I come in and get TAVR if I need a replacement? So again, 30 years ago, we don't know a lot about them. Obviously, you'd have to do, but this is a great question. Thanks for asking that, Bernie.
So, Bernie, if you have a mechanical heart valve, let's say of your aortic valve, you cannot get TAVR put into a mechanical valve. Now, if you, let's say, have a mechanical valve in the mitral position, you can get TAVR done on your aortic valve.
Okay.
But you cannot put TAVR into a mechanical valve.
Okay.
Now, there are two types of surgical heart valves. There's mechanical that require lifelong blood thinners like Coumadin, but there are also tissue valves. And the tissue valves, if they degenerate over time, you can get what we call valve-in-valve, where we take a TAVR valve and put it inside the bioprosthetic tissue valve that the surgeon may have put in 10 to 15 years ago, and now it's become degenerated.
Okay. So this is me asking. We've talked a lot about the aortic valve. Again, eventually maybe I'll have to get that replaced because I do have a lot of leakage in my valve, my mitral valve. Can TAVR also be used for that valve? Because that's more of a loose leaf type thing, so it's a whole different situation, right?
Yeah.
I mean, so mine would be a valve
The
replacement.
technology is expanding.
Okay. I just need to hang on for a while.
Yeah.
Okay. On that note, we kind of are at a 15-ish minute point before the show ends, and I want to kind of stop these questions for a second and make sure that we've talked about everything that you want to talk about. And Rob, I feel like you've done less of the talking because this is like Heart Doc Guy. You have your iPad. Do you have a laundry list of things you want to talk about? I hope so.
No,
so now's the time to do it.
I think the most important part is just, for the individuals to, encourage them to get education on their heart. And I mentioned before, this is Heart Month, and you can go to our website and you can look at those opportunities there. But this is all about the doctors. This is the surgeons, and so for us it's a safe environment. And again, not to reiterate, and you need to come in if you're feeling struggles, if you're feeling pain, call 911, come to the emergency room, and take care of yourself. It's stress related.
Right.
Everybody's having the same challenges. You've got your children at home because of school. You're stressful because you're all being coordinated and you're all in one location. It's tough for everybody. So seek help, talk to individuals. But if you're feeling those symptoms and feeling pain, please come to the hospital.
As you're saying that, educate yourself about the heart. And I want to make sure that when we say that, when you do that, go to peer-reviewed sites. So easy for us to say, to go to a real site. But Googling, Dr. Google does not exist. He's not a doctor at all. But again, you can talk about the hospitals at Providence. That's a great website. Because thank you very much for the show this evening. I do a lot of my personal research on MD VIP. We know that what is on there, the articles that are put on there, there are questions, there's a lot of Q&A that you can do on there. I don't know if either one of you might have a generic website that you use for medical questions. MDVIP is the one that I go to all the time. In fact, when I prepare for these shows, I just go to frequently asked questions on whatever the issue is. So feel free to put in cardiology, heart, aortic valve, mitral valve, and there's also really cool videos. YouTube, be careful there too. Just see if there is an .org versus a .com behind the website that you're going to. Why is that important? Usually .orgs are organizations. .com is different because it's a different hospital site. I think with the Hospital of Providence, but that's very helpful too when it comes to just research, because there's stuff out there that isn't real. Find a real website, go to a real hospital. That information at a real hospital would be correct information.
Yeah, and I think more importantly, it is talk to your doctor.
Yeah.
And don't be afraid to ask the questions to your doctor.
And I think about people who don't have doctors. So yeah, absolutely talk to your doctor.
And if you don't have a doctor, I encourage you to get one. There's a lot of health systems, including the Hospital of Providence, that are using telemedicine too. So you can have those telemedicine visits that you can still get your questions answered.
Right.
The Google helps. The WebMD helps, but nothing beats talking to your physician to ask he or she the proper questions.
Absolutely. And if you don't have a physician, As you said, in the old days, I would say, you know, showing up the emergency room sometimes may not have been the best thing, but like you said, emergency rooms are pretty
Right.
scarce these days. So this is actually kind of a good time to do that and figure out who you can get for your doctor if you don't yet have a doctor. Dr. Ossie, what would you like to talk about? We have all kinds of stuff. Maybe you can show this to the audience.
Sure.
And I don't know if the camera will pick that up, but that's an actual one. And we have Brenda behind the cameras who's jumping around and giving me the time, so a little kudos there too.
So these are the two different types of heart valves that are most commonly implanted.
So Ossie, look at the camera so you can
Yep.
see. There we go. Perfect. That's a better way of looking at it. There we go.
So they both have, they both are good valves. I mean, they both have advantages over the other in certain situations. But what I really want to emphasize is that the hospitals are safe.
Mm-hmm.
I think that that is so key, because I cannot tell you how many times a day that if I feel like I need to admit a patient, they are so scared to go in because of COVID.
Yeah.
But these disease processes,
Or more dangerous.
whether it's coronary disease or valve disease, is more likely to affect you than COVID will. These are life-threatening diseases.
I'm not asking for numbers because I didn't ask you to prepare for that. But in general, because I've been hearing a lot and reading a lot that there are so many people that because they are waiting and not going to the hospitals, that there have been quite a few deaths, and or like you were saying earlier, there's a point of not no return, there's a point of really difficult return because people are not going to the hospitals because of COVID. So
Yeah.
talk a little bit about some of those case studies that you may have seen during this year.
Yeah, we've seen a lot of it. We've seen a lot of people that have delayed their care, that they were afraid to go in because of COVID, and came in with a heart attack that probably could have been aborted, and a lot more heart muscle could have been saved if they had not hesitated. But the fear is there, and I appreciate the fear. I mean, we see it every day, but the hospitals are safe. They have done a tremendous job of taking care of our patients, and I can't emphasize that enough. The other thing I want to point out, again, is the heart team approach. Our heart team approach is outstanding at Sierra. We have a great group of physicians that are physicians that are ultrasonographers that help us get through the procedure. We have the interventionalists, we have the surgeons. And when one patient comes in to be evaluated by me for this, they're not just going to end up being cared for by me, but a whole team of physicians
Right.
and staff.
And in any given surgery, say a surgery that we're doing a replacement here, or an insertion or a deployment, how many people are in the operating room at any given time?
20.
20. And see, sometimes, because lay people like me,
We have the surgical staff, we have our cath lab staff, we have our sonographer, our echo technician, our anesthesia team, phenomenal at Sierra Medical Center. I mean, kudos to everything that the hospitals of Providence have done to help bring us all together.
right.
By building the room that we needed and going through all the motions to get set up to do
So,
procedures like this.
I like that, and that's a great transition to Rob really quick, and I know we're running a little bit out of time, but building the room, that's kind of where someone like you would come in. It's okay, what do my docs need? What does my team need? How do I now talk to the funding department to get the room built?
Right.
Talk a little bit about your role in that.
Yeah, well, I mean, again, you know, it's not just the heart room, but there's other operating rooms too. It's gotta be big enough to fit the equipment, to fit the beds in there. Some move up and down. You got C-arms that cover it. You got lights coming in, out, and too, and so you have to be able to move around. And I think most people don't realize that in these cases like this, there are 20 individuals, literally 20 individuals in that room. So you've got to have enough size where people can move around,
Right.
to do that. So a lot of that comes in to planning, understanding new types of technologies that we consistently invest in. It's costly,
Right.
but it's the right thing to do for the patients, right thing to do for El Paso. But as a hospital, we have to ensure that all of this is set in place. So when we do cases like this, everybody's involved and it's successful.
Exactly. And people, and I'm just going to say this out loud because you were talking about it's costly. And when people think about medical care, yes, it's costly, but there are, my gosh, every time we do this show, it's like something else is on the horizon. Even with mitral valve, you're saying, well, there's new things happening. But the thing is, that also means there are things you have to buy, you know, the different types of screening, the different kinds of things that you use in procedures and surgeries, and that's so very important. And I'm just kind of saying, El Paso has, my gosh, in the years that I've been doing this program, where we have come in the last 20 some odd years. I want to, again, before we start winding down, I want to talk again about getting the COVID vaccine, at least registering for it. I'm 53 years old, I have no underlying conditions, so I'm in group like 99, I get it. But I'm registered, and to me that gives me peace of mind, because when my turn comes, I am at least in the book, so to speak. The places to go, I'm going to give you a phone number and a website. The website to go to is EP, think of El Paso, covidvaccine.com. It's on your screen. And again, if you're not too comfortable with websites, etc., if you type in exactly as you see this here, if you want to put www.epcovidvaccine.com, the window will come up and it will have on there pre-register or register for your vaccine, for the COVID vaccine. It's front and center, and just click on that and it just walks you through it. It actually is, because I don't pride myself on technology, I just don't. When I got on there, I thought, oh, this is easy. Telephone number, 915-212-1032. Again, if you're out of the El Paso area, 915 area code 212-1032. If there's another thing you want to throw away, we've got a good, well, we have a minute, so never mind. I want to say thank you very much to Mariah. You did an awesome job tonight. And I think that Mariah is going to start something new for us. So with all the medical students that come, Mariah, are you in first year, second year, third year? She's a first year. So everybody that you talk to, I like including the names. I love that if the person on the line is okay with that. And also I want to say again, Hospitals of Providence, thank you so much for underwriting the show. And again, each and every month we've got the El Paso County Medical Society for bringing this show to you. Thank you for that. And again, wear your masks. If you want to double up, I think that's a good idea when you're in public. Help is on the way, but we're not there yet. That's so important. Everybody in the County Medical Society want me to make sure to say that. We're still social distancing. I know that we had Super Bowl and a lot of people were together. Try to stay alone if you can, or only go out when you need to. Double up on your masks and stay safe. Thank you so much. I'm Catherine Berg, and this is the El Paso Physician. I love the stretch. Thank you. Because sometimes, because I don't know sometimes. It's like.